We described the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for the treatment of STIs and explained the pathophysiology and clinical presentation of some of these STIs. Now let's interpret diagnostic laboratory findings to confirm the presence of genital herpes, gonorrhea, chlamydia, or syphilis in a patient. Let's take a look at diagnosis of genital herpes simplex virus infection. Now, if the genital lesions are present, clinical diagnosis should be confirmed by a type-specific virologic testing from the lesion, and that's typically with a nucleic acid amplification test, and that has a pretty good sensitivity of that approaches almost 100%, so 91 to 100%. Whereas if you were to culture this, sensitivity of viral culture is low. And then there is a type-specific serologic test. So serology is actually from the blood, whereas that nucleic amplification test was done on the specimen directly from the lesion, which means there is no lesion. You can't really do this test because you need to have a specimen. Whereas serology can be done at any time, whether there is lesion or not. So essentially, you want to see if someone has, latent HSV. And the serology test that's type specific, it can distinguish between HSV1 and HSV2. It essentially detects different glycoproteins from each of these. And it has a good sensitivity, 80 to 98%, but it has a poor specificity. So when there is a positive test, you have to make sure that it's not a false positive. So it needs to be confirmed with a second method. Now, these say type specific because there are some tests out there that are type common antibody tests. They just tell you if somebody has HSV infection. It doesn't distinguish between HSV1 and 2. So the CDC guidelines from 2021 do recommend to use type specific so you can distinguish between HSV1 and 2. And that's implications for treatment because we know that if it's HSV1, it's less likely to have recurrences, whereas HSV2 is more likely to have recurrences. So that essentially determines our treatment strategy, which we'll cover shortly. Now, when it comes to screening, these are the US PSTF recommendation. So they recommend against the routine screening by blood test, so essentially the serology test, for genital herpes infection in asymptomatic people, including pregnant individuals. So it's not recommended. It's only when people have symptoms that then you essentially do the NAAT and diagnose them with genital herpes. Now, when people do have genital herpes, those ulcers actually increase the risk of HIV transmission. So for that reason, all persons with genital herpes should be tested for HIV. Now, diagnoses of chlamydia and gonorrhea are pretty similar. So essentially, you use nucleic acid amplification test from the specimen, and the specimen is essentially the site of infection. So for women, if it is a urogenital infection, so vaginal or cervical swabs, or you can use a first void urine test to detect either chlamydia or gonorrhea. And typically these are tested at the same time. So because the manifestations are pretty similar, when you suspect one, you test for both of these. So that makes it more straightforward. For men, urethral infection can be diagnosed again using first void urine or a urethral swab. And I will tell you that most routinely people just get the urine sample for these. If you suspect the route of transmission was rectal or oropharyngeal, those sites can also be swabbed because a urine sample might test negative where somebody may have oropharyngeal infection. So all three sites may be needed to be tested in certain individuals with risk factors. And something that's specific for chlamydia and gonorrhea is that patient-collected specimens are equivalent in sensitivity and specificity to those collected by a clinician using NAATs. So it doesn't matter if the patient swabbing, for example, doing a rectal swab on their own, or the physician doing it. So technique is not really as important, or at least the studies have not shown much difference. Now, while we're doing diagnosis of chlamydia and gonorrhea, because of the common risk factors, these people should also be tested for HIV and syphilis. Let's take a look at diagnosis of syphilis using serology. But first of all, T. pallidum cannot be cultured outside of specialized research laboratories, and there is currently no FDA-approved nucleic acid amplification test for syphilis. Therefore, serodiagnostic tests are the only means for screening and diagnosis of syphilis. Now, serologic tests for syphilis are broken into two groups. The first group is non-treponemal tests, or NTTs, and these essentially measure the IgM, which are acutely elevated, and IgGs that are elevated for lifelong in response to lipoidal antigens. Now, lipoidal antigens are present in both T. pallidum and host tissues and may be present in other inflammatory conditions, including systemic lupus erythematosus, and infections including HIV, Hep C, CMV, and parvovirus B19. NTTs are also quantitative, so not only they test as reactive or non-reactive, but they can also give quantitative measure of titers. And the ones that are commonly used in the US are the RPR, or rapid plasma reagent, which is essentially used on plasma samples, and there is also VDRL test, which is used on CSF or plasma samples, but most commonly on CSF for diagnosis of neurosyphilis. And that's Venereal Disease Research Laboratory is the name of this test. The second group of serologic tests are treponemal tests, or TTs, and these measure antibodies directed against T. pallidum, and these are qualitative, so this will result either as reactive or non-reactive, but not necessarily measuring a titer. And the most commonly used in the US is the FDA ABS, or fluorescent treponemal antibody absorbed tests. Now let's take a look at the kinetics of these serologic responses. So essentially, you can see that the first group, which is treponemal tests, once the patient has infection, these levels start to go up, and then they peak during secondary syphilis, and then even if the patient gets treatment, these levels continue to be elevated throughout life. So while it is useful for initial diagnosis, if someone gets reinfected, this is not as useful because the first infection will result in lifelong antibodies in most individuals despite successful treatment. The second group, which is NTTs, most commonly RPR, these are again start to increase during primary syphilis, and they peak during secondary syphilis, and then even without treatment over a lifelong they start to decline slightly, but with successful treatment they will get a sharp decline. In fact, the definition of a cure is a fourfold or greater decrease in the NTT titer after treatment, which represents cure. For example, going from a 1 to 64 dilution to a 1 to 16 represents at least a fourfold decrease, which I will explain further on the next slide. Now, there are two situations that could happen. Most people who get successful treatment, they actually seroconvert, meaning that these levels will no longer be detectable. However, up to a quarter of patients after successful treatment, they continue to have detectable levels of these antibodies, but of course this would have declined by more than fourfold after treatment. Now let's take a look at the titer serial dilution, which is what we do with syphilis titer. So essentially, when you get a sample, depending on how much antibody is in that sample that's detected, they will continue to dilute it in half. So these are serial dilutions, and each sample is essentially diluted to a half relative to the previous one, and they keep doing this until the antibodies are no longer detected. So essentially the way the titers are reported is the last dilution where it was reactive, they would report that as a 1-2. So for example, if we have a sample that was reactive in the first one, reactive in the second one, reactive in the third one, reactive in the fourth one, and non-reactive in the fifth and sixth one, they will report this as a 1-to-8 dilution. That's how they measure. So when you have less of the antibodies, this will become non-reactive faster. So a 1-to-2 is actually you have less of the antibodies compared to a 1-to-32 dilution. And the way we measure changes in these dilution is that, for example, if initially somebody had a titer of 1-to-32, if on follow-up measurement it goes to 1-to-16, that is a twofold decrease. And that, because these are halved, we're essentially looking at binary base. So 2 to the first power is 2, so that this jumps from 1 dilution. So this is twofold decrease, which is not enough for cure. In the second example, when it goes from 1-to-32 to 1-to-8, this is 2 jumps. So 2 to the second power is 4, so that's a 4-fold decrease. On the third example, it goes from 132 to 1-to-4, and this is 3 jumps. So 2 to the third power is 8. So this is considered 8-fold decrease. And of course, the first example is not considered cure, whereas the second and the third examples are proper response to treatment. So those are considered treatment. And vice versa, if somebody was to have increased titers when it comes to syphilis serology, if it goes from 1-to-16 to 132, this is 1 jump. So that's a twofold increase, going from 1-to-8 to 1-to-32. That's a 4-fold increase, and so forth. Now let's take a look at 2-stage syphilis testing. Because these tests are not perfect, and there is a risk of false positive and false negative, there are 2 different ways to do it. One is a traditional algorithm, which is essentially that you start with the NTT test. So let's say with the RPR, and if it's non-reactive, you can assume that the syphilis is unlikely. It's possible for early syphilis to have a false negative, so take that with a grain of salt. But in general, if there's been enough time, for antibodies to develop, a non-reactive will mean syphilis unlikely. However, if it's reactive, there's also risk of false positive. So you will do a second test with treponemal test, and if it's non-reactive, you assume that was a false positive, or perhaps other situations that's not syphilis. However, when you have both of these positive, that's confirmation of syphilis that would require treatment. Another way to do it is the reverse screening algorithm, and the reason this is more common because the risk of false negative on the initial test is higher with the traditional algorithm, whereas the risk is a bit lower with the reverse screening for early syphilis, and that's only for initials. And this is where you start with your TT test, and if it's reactive, you go to your NTT, and if that's reactive, you assume you confirm syphilis, and you essentially treat. Whereas if the first one is reactive and the second one is non-reactive, you do confirm with a different TT to get confirmation. If you have 2 non-reactives here, you essentially say this is syphilis unlikely, whereas if this is reactive, you do treat. So this one is a bit more complicated, so I suspect more centers do traditional algorithm, whereas reverse screening is starting to become more used. From the CDC guidelines, either of these methods of screening is fine. It's not that one is preferred over another.